Again, hello and welcome to the Parkinson's Foundation Wellness Wednesday webinar. Today, we talk about the experience of changes in speech, voice, and swallowing. I'm Jenny Fierde, Community Engagement Manager for the Parkinson's Foundation. Please share in the chat where you are joining from today and say hello to your Parkinson's community. We are recording today's presentation, and you will receive a follow-up email from us with a link to today's recording and other resources in the coming days. Before we begin the formal webinar, I would like to share a little about the Parkinson's Foundation. The Parkinson's Foundation is a nonprofit focused on bettering the lives of those living with Parkinson's through improving care and advancing research. Everything we do is in close concert with our community to ensure that our actions are aligned with the needs and priorities of those living with PD. We are focused on improving care for those living with PD, advancing research towards a cure, and empowering our global community. To achieve our mission, we pursue 3 goals: improve care for everyone with Parkinson's, advance research toward a cure, and empower and educate our global community. Today's program is a great example of one of the things we are doing to help us meet these goals. Now, if you are looking to get more involved, we're excited to share our initiative meant to capture the community's perspective on various topics in Parkinson's disease. We hope that you'll join us by signing up for this initiative, where we invite you to complete a 10 to 20 minute survey on various topics such as mental health, telehealth, and care partners. We will always report findings back to the community. You can learn more at theparkinsons.org/PF surveys. Today's PD Health at Home program is presented by MERS Therapeutics and the Light of Day Foundation. We want to take this moment to thank MERS Therapeutics and the Light of Foundation for supporting the mission of the Parkinson's Foundation. Again, as a reminder, the Parkinson's Foundation provides weekly educational and wellness programs virtually through our PD Health at Home series that includes our days, Mindfulness Mondays, Wellness Wednesdays, and Fitness Fridays. As a reminder, all programs are held at the same time, 1 p.m. Eastern Standard Time. In addition, for those prefer information and the virtual programs in Spanish, we also have Epe Salud en Casa, which we offer the last full week of the month at the same time, 1 p.m. Eastern Standard Time. You can learn more and register for these programs by visiting parkinson.org/PD Health. Now, as we close announcements, we settle in for our webinar on speech, swallowing, and drooling. Most people with Parkinson's disease will experience changes in speech, voice, and swallowing at some point during the course of the disease. In this webinar, you will learn about tools and exercises to help you better understand and manage speech, swallowing, drooling, communication, and other oral problems in PD. We hope you come away from this briefing understanding voice changes. People with Parkinson's may experience what swallowing challenges are associated with PD, strategies to manage speech and communication problems in Parkinson's, and options for treating and managing drooling and swallowing difficulties. Now, I'd like to share a bit about our expert speaker today. Dr. Kenneth Martinez is the founder and director of the Neurology and Pain Specialty Center in Aliso, Viejo, California. He obtained his medical degree from the Keck School of Medicine at the University of Southern California. Following this, he finished his internship and residency at the University of California, San Diego Medical Center in 2000. Dr. Martinez holds board certification in neurology and headache medicine. He serves as the medical director of the Movement Disorder Program at the South Coast Health Center in Aliso, Viejo. Besides his thriving practice, Dr. Martinez has gained national recognition for his dedication to excellence, which is evident in his involvement in active patient support groups, research, and education. Welcome, Dr. Martinez.
Thank you very much to the Parkinson's Foundation. to give us this opportunity to talk about something that doesn't get as much attention as potentially it should. So often we talk about the motor issues surrounding Parkinson's, and this is one that's a little more tricky than average and not as straightforward. So I'm glad we sort of have a dedicated time to be able to talk about this kind of combination of, speech, swallowing, and drooling, a lot of these kind of oral um, issues that can affect Parkinson's, and it really deserves its own focus time and a chance to ask questions because it's very impactful. We can become very self-conscious about a lot of these. And so at our center, and I had a kind of a multiple clinician team. I work with 4 PAs, a nurse practitioner, an RN, and a coordinator focusing on the Parkinson's end of things here and other movement disorders. And so we try to offer really multiple interventions that help both from, counseling and working with outside therapists. And you'll notice I'll put a big emphasis on speech therapy. And for all folks in Parkinson's and clinicians who are in your area, encourage your neurologist, or even if you have just a primary care doctor, to form an alliance with the speech therapists because they will be invaluable in terms of ongoing education and troubleshooting and individualizing a lot of the care. Everything we talk about today, these are all ideas or troubleshooting, or sometimes even individual cases that I'm going to discuss that I've seen help with in utilizing a lot of other of these interventions, both practical, non-expensive choices, as well as therapist interventions, certain ideas for exercise, although the follow through with the speech therapist will be the most helpful to everyone affected by this. But then also some ideas that sometimes you can be proactive about asking your neurologist or movement disorder team on whether it's time to consider some of the more aggressive interventions, including certain medications or off-label uses with the medications. But this forum is really about coming up with troubleshooting. There's no one person's brain who knows all of the solutions to this. So, this is meant to stimulate discussion, ideas, and see if we can have more traction and results with these refractory problems. So we'll sort of, take them one at a time as we're going through them, and I'll bring up different ideas as we go along that we've used, and that oftentimes my team and I will discuss individual patients and oftentimes brainstorm what can work for each individual person, because not everyone's going to tolerate every one of these types of interventions. So let's start with speech. One of the things that lots of patients with Parkinson's will notice at one time or another. So might arguably be the most common of these three issues of speech, swallow, and drooling. So in this regard, speech difficulties that can occur with Parkinson's can start as something as simple as just hypophonia, which is this decrease in volume of the speech. And that's by far and away probably the most common. That can, also take the form of something such as mumbling, or where it's harder to enunciate with formation of the words using lips and tongue. But it can also be just, a vocal cord related phenomenon where the volume of your speech decreases and you're not able to really project as well. Or interestingly enough, there's been a lot of other research that's looked at the fact that the Parkinson's person thinks they're speaking at what they would consider a normal volume, but everyone else really has a harder time hearing them. And so many times, one of the main techniques that's used for hypophonia is working with the speech therapist in projection. And there's something known as loud therapy that many speech therapists are trained in that help train the Parkinson's person to think consciously about the projection of their speech and to think about being loud. And when the Parkinson's person sometimes then thinks they're almost yelling, but we all can hear them. And of course, you're also faced with the conundrum of all of us tend to lose our hearing as a population as we age. And so that can be, also a challenge. To combat that, one of my suggestions to loved ones and family members is, both the patient and those interacting, is making sure that you don't talk over your shoulder. If they're behind you, remember to turn so that the person can hear you, consciously knowing that your speech is going to be at a little bit lower volume. Even simple things like that can lead to less dissension in the home, or difficulties about that. If the Parkinson's partner has actually any hearing loss, interestingly enough, actually hearing aids for the partner or caregiver can really be helpful, just to make it that much easier to hear the patient with Parkinson's. So, but really, working on the Parkinson's patient, with their voice projection seems to be by far and away one of the most helpful. Um, and really, it's the speech therapist will give you exercises to do. Some practical ways to improve volume of speech. This was especially true during COVID and when we were living alone, is something as simple as even like reading newsprint or a magazine or a book out loud for 10 minutes or 20 minutes and working on projection. During the time of COVID, I had a lot of people have increased hypophonia because they were actually in social isolation. We just weren't using our voice as much. And just like with any muscle, if we aren't speaking as much, if we're mute for prolonged periods of time, those muscles can atrophy, and then we lose the ability to project as well. And I had definitely had patients lose a percentage of their speech volume just from lack of use. Now, you can do those sorts of just simple formal things that you do at home. And that's one of the simplest things that the speech therapists remind people to do. And if you make it kind of a daily habit to at least, do that for a period of time, that really does help. Oftentimes the speech therapist will have you sometimes do it in the mirror as well. And that can oftentimes retrain the brain to help increase the volume. Um, the other Another useful tactic, if you have this available, is groups such as the Tremble Clefs. Locally, I have a group that call themselves the Tremble Clefs. I like the clever name, of folks with Parkinson's who practice singing, and then they'll give different concerts as they practice different songs over the course of the year. And those have been really great at a number of different events. Like we had a moving day organization a few years ago that they came and they kind of gave a concert as part of the opening ceremonies of it. And that was a really great way to to kind of increase the interest and fun of practicing with this. Obviously, across the country and in other parts of the world, church choirs are a very good option to be able to do that, or other get-togethers, even family get-togethers where there's sing-alongs. All of these things, even though you're like, those are just fun, but that makes a difference, and you're using the voice. And of course, when we're singing, we're actively projecting, and essentially you're using your cortex, your brain, to help override and try to get a little more oomph out of the volume of the voice. And that practice really makes a significant difference. So that's what those are the main things that most people with hypophonia, this decrease in volume of the voice, would benefit from. A couple other isolated cases, much more rare, is that you might be having a problem with something like they call it spasmodic dysphonia. So that's a spasm. Think something like writer's cramp, a version of dystonia, abnormal contraction of the muscles, but affecting the vocal cords. And so Parkinson's patients are more prone to that. Now, instead of kind of the breathy whisper of a Parkinson's person, you might get more of a kind of a tight voice that I'm demonstrating, and hopefully that's conveyed in the audio. That more tightening of the voice, that might be a greater indicator that there's spasmodic dysphonia going on. And that might respond to very, very tiny doses of injectable botulinum toxin, such as Xeomin and others, that can help to relax those muscles. We're not injecting into the vocal cords, we're injecting into the muscles near them. So that should be done by either a highly trained, either movement disorder specialist and neurologist, or ENTs who have some familiarity with that. In my local area, I'm lucky. I have three doctors: Dr. Feinberg in Newport Beach, Dr. Jacobson in Mission Viejo, and Dr. Verma at UC Irvine. All of whom have been able to provide this service for my patients, and they know how to do the micro dosing. It's really sometimes even a fraction of a unit of one of the botulinum toxins. Sometimes can make a significant difference when it's spasmodic dysphonia, but oftentimes it's helpful because they can actually see it and help distinguish. On the flip side, sometimes patients don't have that problem. Sometimes they actually have true weakness of the vocal cords, and that would be more of the breathy whisper. And their vocal cords, if you look down the throat, the vocal cords oftentimes will look like these two fingers. And normally the vocal cords will come together to help create phonation. In Parkinson's folks, that coming together, the vocal cords is oftentimes limited. And so when that's the problem, and the ENT, ear, nose, and throat, head and neck surgeon can look down and can see the vocal cords are having a struggle coming together, in that case, we wouldn't use botulinum toxin. We would instead, one of the more advanced ways of helping that is something called filler. Now, you've heard of filler. This is what you use, what folks would use for increasing the size of lips or filling in wrinkles. It's not botulinum toxin. Botulinum toxin would relax the muscles. Filler, on the other hand, fills up the tissue and fills up the creases. In this case, the vocal cords, if you're looking down the throat, they would inject filler to be able to move the vocal cords closer together, which I'm trying to demonstrate with my fingers. That getting them closer together helps them to create the phonation. And that's really good when people have these very breathy sounding voices and they're having a hard time generating any kind of phonation. And that's been sort of a godsend. It's a small subfraction of folks, and your neurologist and movement disorder specialist will make that referral close by. Lots of the university centers will also have specialists who are trained in distinguishing between whether it's a spasm and requires botulinum toxin, such as Xeomin and others, or whether you need a filler in terms of trying to alleviate that. Okay, so that's been one of the more exciting ones. The only issue is if you require botulinum toxin, usually you're re-injecting it about every 12 weeks, about every 3 months. Sometimes people can go a little bit longer with it. On the other side, if it's filler, that oftentimes lasts a little bit longer. And so I've had it last anywhere between 6 to 12 months. I'd probably say on average it's closer to like 5 to 9 months. That injection will help alleviate it. And then, and I'll come back to the filler in a bit for one other sort of, again, off-label use of it that's been helpful for another one of the three issues we're talking about today. Okay, so so that's really dealing with hypophonia phenomenon and the different manifestations. I should give some at least direction to other effects on speech that can influence people. Excuse me. So one of them is sometimes patients will have almost like a stuttering to their speech, very similar to when we've encountered children who have stuttering in their speech, and then they'll get stuck on the speech and encounter that. And so they can phonate oftentimes reasonably well, but the speech will have that stuttering quality to it. Oftentimes, we would approach that a little bit differently. If that's part of manifestation, then I would look to see, okay, do I have potentially an undertreated anxiety phenomenon? A lot of the meds that help with anxiety will also sometimes help with some component of that stuttering speech, and that may be worthwhile. Now, that could be some of the serotonin replacement medications, such as, things like Lexapro, Prozac, the sertraline, etc. Medicines from that family can be sometimes useful for that. or even sometimes some of the sedative medications like clonazepam. So that's when I would start to analyze, is the person encountering that more significantly, and is it having some association with sort of slowing of the thinking, or that their thoughts are going too fast and racing and their speech is having a hard time keeping up with it. So, and so that can be a component that would sometimes respond, but that's a little bit different approach. And we know that anxiety, depression happen at a much higher rate in our Parkinson's population. By some estimates, 80 to 90% of people may encounter that. And so the stuttering pattern of speech oftentimes is associated with that. And so, just a little bit different approach that would usually work for them. Also, I would also take a good look at their dopamine medications. Are they noticing speech problems either when they're peaking or when they're going off? If that's true, I might start utilizing meds that try to even out the dopamine levels to avoid some of the peaks and valleys. So any of the long-acting versions of carbidopa, levodopa, long-acting Rytari and agents like that, or any agent that prolongs the effect of the carbidopa, levodopa, the COMT inhibitors, and the MAO inhibitors are all potential categories for that speech problem when it's intermittent throughout the day. Okay, so those are kind of useful variants to really look at. Separately, we might also, sometimes I have people have slurring of their words. I would also look to see, hey, is that a new issue? Is it fluctuating? Is it occurring possibly with dehydration at certain times of the day? Or is it maybe associated with some mental status change? That can be an indicator that there may be a delirium, like an infection or dehydration, or a new medicine was given to you. So these are the things that, you and your loved ones paying attention to what may have been new that may have triggered that will oftentimes help your physician and medical team identify what is there something that's changeable that got recently added, or a new medical condition that now has affected you. Okay. All right, so those are all some good examples, and I had one more issue with speech that I wanted to discuss, which is dyskinetic speech. Dyskinetic speech would be, again, frequently when your dopamine level is peaking, and if your speech suddenly becomes more difficult at that point. And likewise, I've also seen, and sometimes medicines that work against dyskinesia, whether it's evening out the dopamine or using even sometimes a medicine like amantadine, in those individual cases, those anti-dyskinetic effect medicines or the long-acting amantadine Gocovri might potentially make a difference in those individual cases. Okay. All right. And I had mentioned that if there was actually slurring that's kind of new, which I'm kind of demonstrating now, where there's a slurring of the words that's new and different, and there is an underlying infection or other illness or new medicine, obviously treating that or identifying it and changing it can make a difference. And oddly enough, I've actually seen that happen to people, even from something like constipation, which can sometimes lead to higher levels of ammonia in the blood. And so if that's going on, I've actually had people, that is not a common issue, but I wanted to let the crowd know that these are all the other general medical issues that can sometimes affect people's speech patterns. Okay. But again, most importantly of all is get a referral to a speech therapist. And oftentimes they will help us if they're struggling with you or identifying these different patterns. Plus, they're also very good at identifying when there's a more of a cognitive communication issue. I'll give an example of people who have slowing of their speech. They're perfectly understandable, but really there's this delay. Oftentimes in Parkinson's patients, I need to be patient and let you get your words out. But there is sometimes where it's too severe and there's just too much of a delay, and that can be an issue. The only thing I've seen sometimes help that part of it, that's oftentimes connected with a norepinephrine neurotransmitter deficiency in the brain. And I have occasionally seen the stimulants such as methylphenidate, known as Ritalin, or sometimes Adderall, those stimulants will sometimes help with the speed of cognitive processing and the speed of thought to speech. Again, selected groups, you should always be able to know with a relatively low dose and a quick trial over 2 to 4 weeks on whether that's going to make a difference in the person. And it should be very noticeable to you, the patient, the family, and the clinician. Okay. All right. So I'm going to move then to swallowing issues. So much smaller percentage of patients, notice severe swallowing issues. More commonly, a large number of Parkinson's patients will notice mild swallowing issues at some point in time. First of all, it's always important to look at other potential contributors. Postnasal drip from allergies or acid reflux can sometimes irritate the esophagus. And those are general medical issues that sometimes are worth at least bringing up to your primary doctor and should be potentially addressed before seeing the neurologist in case they're contributing. Let's assume, though, those are not contributing. And so then when we start having some of those mild swallowing issues, then you identify, okay, is it thin liquids like water, or is it chewy foods like chewy bread or chewy steak that's really impacting people the most? And then making those, and then modifying the diet, sometimes using smaller bites, or trying to soften those types of foods, gradually. Working with a dietitian and the speech therapist, again, oftentimes you can start to modify the diet into things that are easier to swallow. Pills are oftentimes one of the biggest challenges for people. And even though we drink it with water, we think that makes it easier. Sometimes it's better to take a pill with something like applesauce or pudding or ice cream, or something that's has a little bit more texture. Sometimes a thickened drink like a Kern's Nectar or an Ensure. Those are just a little bit thicker, almost like a milkshake consistency, or at least just something slightly thicker than water, will definitely make swallowing pills significantly easier. One of the easiest things, at least locally, is something that you can add to thin liquids like water, which is something called thicket. And that tends to increase the viscosity of the fluid you're drinking, and it makes it much easier to swallow, number one. And then number two, it makes it easier to take pills with as well. So those are some very simple solutions that you can implement yourself, because that doesn't require a prescription. That's over the counter at any of the pharmacies. And can make a dramatic instant difference in terms of like less anxiety for taking pills if you feel like things are getting caught in your throat. All right. So that's though, and you can also, if you're having certain pills, you can move to sometimes modified versions of the pills, depending on the pills. And we're talking both the general medicine pills that you take, but also the Parkinson's medications. They do come in other formats. There's, for carbidopa, levodopa, if you're on the immediate release, they do sell a generic that used to be name brand known as Parcopa, which dissolves in the mouth, so you don't have to swallow the whole pill. Obviously, you can crush your pills and kind of mix them with either applesauce or other, thickened foods like, pudding, etc., that makes it easier to swallow, and then you don't have to swallow the whole pill. That's also a perfectly reasonable solution. There's a number of meds that do come in different formats that's worth discussing with your clinician, at least proactively, just, hey, or with your pharmacist, like, hey, does this come in any other form that I can ask my physician to prescribe? Those types of things really make a difference. One of the biggest challenges has been a medicine I use very commonly. The old brand name was Cymbalta, but it's also, the generic is duloxetine, and I use that a lot for anxiety, depression, pain, and mood issues. And so that's really made a big difference in the quality of life of my patients. But its granules are notoriously challenging, so they oftentimes have to be given in a capsule form. But it can be opened, or they come in a granule form that can easily be opened rather than just being a closed capsule. And so that's also true of long-acting Rytari that we use in maintaining people's dopamine levels as well. That's a long-acting version of carbidopa, levodopa. Okay, so those are just all some different, at least talk with your clinician that all of these other variants do exist. And I can't even be comprehensive in discussing them, but it does require you bringing up the issue and then just saying, hey, I know there sometimes are alternate forms. Amantadine, for instance, comes as a liquid. Some meds, not that many meds in Parkinson's are available in liquid form, but there are, a few other, powder or, capsules that you can open up and spread on the medicines. These are all ways to get around the challenges. And, and it's better to be able to stay therapeutic with these meds and not, have missed doses or unnecessary anxiety because of the fear of swallowing. Okay. Um, okay, I think that's one of the main things I wanted to be able to talk about on that. Again, working with the speech therapist, sometimes we'll do a swallow study, which is using an X-ray video swallow to look at a person's kind of risk of aspiration. That's the ultimate thing we're trying to avoid, is food going down the wrong tube and into the lungs, therefore potentially causing an aspiration pneumonia. And you're right, those are the types of things that we're doing. Speech therapists will oftentimes both analyze that video swallow. Sometimes we'll also get the ENT head and neck doctors to do a scope and look and see if there's any other mechanical reason, little masses or growths or something that the ENT would address. Those can all be very useful at ruling out, because we'd hate to miss that and just blame it on Parkinson's. So that one screen sometimes is useful. And the speech therapist and their video swallow is very good at helping identify when that's needed, to look a little bit more closely. All right. And okay, so that's, most of what I wanted to be able to at least focus on swallow, with the one exception that frequently what the speech therapist will tell us is a very simple thing you want to take away is if you are taking your pills or food, a couple things to do is making sure that you're looking straight ahead and not trying to swallow with your head turned to the side or trying to talk to somebody. That, when you're eating, you're tending to focus on eating when you're having this dysphagia, this difficulty with swallowing. And so, focusing on the eating and not focusing on the conversation, it's like either eat or talk, but don't try to do both at once. The second thing is when you take the mouthful, in the upright position, sometimes then tucking your chin will help to close off your airway and kind of help force the food back into the esophagus where it needs to be, and be able to go down into the stomach, and that helps facilitate the appropriate swallowing. Again, not trying to swallow while your head is turned, because the dynamics of your muscles are not optimal in that position, and you need every ounce of good coordinated movement of those muscles to enable a good swallow, or at least like have fewer near misses where you're having partial aspiration or coughing, etc. Okay. And obviously speech therapists can help guide you, and it's a trained, learned technique, and behavior that makes a big difference. Okay. Now I'm going to move into kind of the third category about, really drooling, or maybe we should just say increased or difficulty with management of secretions in Parkinson's. So oftentimes, this takes the form of a few different things. It can be frank drooling, which is oftentimes coming out the side on one or both sides. Oftentimes drooling, when studies have been done, it's not very often that there's actually an increased saliva production. What it ends up being is with Parkinson's, the muscles of the face stiffen, right? And so just like the muscles of the arms and legs are stiffer and less likely to move spontaneously, that's true of the muscles of the face. And when the disease becomes, far enough, the lips, which I'm demonstrating with my fingers, will become unsealed. And so at rest, the person's lips are no longer sealed. And that's one of the things that in all of us, just that simple sealing of the lips is what keeps saliva in the mouth and then eventually encourages it to go to the back. So that's one thing working against the Parkinson's folks, is the lack of seal of the lip, and can really be that simple. Additionally, and rather than an overproduction of saliva, the other thing that can hit Parkinson's patients is you can also have, both from effects of the Parkinson's, but also effects of age and effects on the spine, is you'll have a forward flexion of the neck and sometimes a downward tilt of the chin. So now you've got the production of the saliva, but it's running downhill. Instead of being on a flat surface, now all of that water, saliva, is going to be running downhill out the front of your mouth. If you combine that with the difficulty with seal of the lips, Thus, the drooling can happen. Now, obviously, drooling isn't just an annoyance. It can cause actually skin breakdown from increased moisture. It can cause fungal infections, etc. So these are, there's lots of good reasons. It's not just purely a cosmetic issue. So, all right. So if these are the mechanics, then how can we then combat it? Okay, so the first and foremost thing is, I would use the FDA approved treatment, botulinum toxin, which is Xeomin, which is the only FDA approval for it, to target the parotid gland, which is one of the salivary glands here in the cheek, right under my finger, and the submandibular gland, which is right under the jaw. So those two targets, produce a large majority. It's not the only salivary glands. There is a sublingual gland, but we can't get to it. It's right under your tongue. But these two glands, the parotid and submandibular glands, can be injected with a single injection to each of them for a total dosing of about 100 units of Xeomin to target and calm the production. Now, it doesn't shut off all of your saliva production, but it can turn it down significantly where you don't have as much production of the fluid. So that's one thing that's pretty straightforward, starts working within 3 days after the injection, peaks about 2 weeks after it, and can last for 3 to 4 months at a time. And then will require reinjection as the botulinum toxin wears off. Now, this is the same botulinum toxin that we use to get rid of wrinkles and that we use to relieve muscle spasms, etc. So, so very, very potent, very useful, clean, effective, usually safer in an older population without a lot of the oral medication interactions and exposures. So that's a big deal in this Parkinson's population because it's not a pill, it's not going to interact with those other medicines. Main potential risks would be, well, sometimes I can overly dry the mouth and I can just cut back on the dose the next round, or I could, there's always a little bit of chance of jaw weakness because it could seep into the masseter muscle. I haven't had that happen very often as long as I stay superficial, but that's a theoretic possibility that you might have a little more difficulty chewing. And those are the main risks. And so the main thing we're trying to get rid of is not cause any increased swallowing difficulties, right? And so with proper placement of the submandibular injection, that decreases any risk of swallowing difficulties. But that is one that we should always be wary of, especially because Parkinson's patients already have a little bit of difficulty with swallowing. Okay, now, other things that can shut down the production of the saliva, there are oral medications, but they're all going to come with more side effects. And so, I usually go to botulinum toxins, and if I have to clean up something else, then I might use a medicine such as glycopyrrolate, or other medicines with an anticholinergic effect, which can dry the mouth, kind of similar to how most of you may have had Benadryl or one of the other antihistamines and get a little dry mouth from it. They're all medicines trying to use that effect to aid people. I've even used atropine drops, a couple drops under the tongue, swish it around in your mouth and then spit it out. And sometimes that will calm it. All of this family, whether it's, amitriptyline, a medicine called Artane, trihexafenadil, these are all examples of medicines in that family, and they all have the same risk of memory problems, confusion, and disorientation. So those are all the types of side effects of memory problems or excessive dry mouth or mental confusion. So I always tend to now use them second line. Since the botulinum toxins have made such a difference cleanly, that's been clearly superior for the most part. But I wanted to be comprehensive in telling you about other options available. Now, we talked about, kind of turning off the faucet by shutting down the production. But now let's talk about those other things. The sealing of the lips. Well, I don't have a medicine for that, but I do have, if you go to the doctor's office, a lollipop can make a surprising difference. Now, that could be something as simple as a mint or a lollipop gum. Something in the mouth will entertain and distract the mouth and will enable you frequently to keep the lips sealed better. So that can be surprisingly helpful. Now, I was teasing about the lollipop. You can use it, but sometimes even just the lollipop stick, having it, at the corner of your mouth is a tactile reminder to keep the lips closed in order to keep the, people have used a toothpick in the past, or I like a lollipop stick, or, technically it could be anything that's, as long as it's not going to get dirty or yucky, and don't be afraid to replace it. But, those are the types of things. But even something inside your mouth, even though gum and candies increase saliva production, they can sometimes really help with the drooling by keeping the lips sealed better. Okay. The other thing your doctor can do is, we talked about the head position. And if you have that little bit of forward flexion, sometimes there's also a role for the botulinum toxins, such as Xeomin, to help decrease that cervical dystonia, that contraction of the muscles that's pulling people forward. And just by, sometimes if I can get their head up another, 5 degrees, sometimes that's going to be enough to combat the slope effect. And now the slope of the line isn't as bad, and the drooling won't happen nearly as frequently. I've had some patients with Parkinson's with a pretty significant cervical dystonia that I'm demonstrating, and if I can straighten their head up, I can oftentimes combat the drooling issue as well. The other reason to really target drooling, and I think this will be my last point before I open it up for questions, is, people can have a lot of difficulty managing secretions, not just in the daytime, but sometimes at night. And so if it's a nighttime secretion issue, then kind of elevating the head of the bed to about 30 degrees, or about at least 2 pillows worth, or if you have a bed that angles, that can be really helpful. But I can't tell you how many times and how many lives I've saved targeting with botulinum toxin to the parotid and submandibular glands, and I dramatically decrease those nighttime secretion productions when the person is unconscious and sleeping. And and they were just having, their partner is really describing that they're having coughing and choking and waking up, and that's really made one of the biggest differences for that particular aspect. Both the angle of the bed, but then sometimes just decreasing the production of the secretions, in terms of just quality of life, quality of sleep, less anxiety for the partner, less anxiety for the patient, most importantly, in terms of just worrying about that part of things, and fewer visits to the pulmonologist or to the emergency room for an aspiration pneumonia. Okay, I think I hit most of the points that I wanted to cover, and some practical solutions that we've encountered in our practice. But now I'd like to turn it over to you, and address any other questions that have come in from the audience that I can maybe target more directly.
Yeah, no, thank you, Dr. Martinez. And I just want to remind folks that if you have any questions for Dr. Martinez during this Q&A session, you could submit it through our Q&A icon, and we'll try to gather them and address them with the time allotted. But I thank you so much. There was so much, key points that you addressed. And I think one of the things that kind of sit and resonated, obviously, as we work with the Parkinson community, you discuss how excessive drooling can occur due to the stiffness of the facial muscles. And this is very important because, one of the key points and message that we convey to our Parkinson community is the importance of strengthening their muscles to improve gait, and obviously coordination and whatnot. But the importance to recognizing that we have facial muscles and many other parts of our body, and how we have to often strengthen those to help us improve with, obviously closure of our mouth, so that we do not have these excessive drooling. Do you think the same principle applies to in terms of engaging in a multidisciplinary activities like loud movements, as you mentioned, reading out loud, or speech therapy? Could that help prevent, if they were to utilize these activities ahead of time before these symptoms show?
I would absolutely tell you that proactive exercise with your voice in this case, and especially in that front, and at least being aware of some of the challenges that any of us could encounter, Parkinson's or otherwise, in terms of like choking on foods, and how not to get distracted during a meal. These are all things that we should put into early practice. But that can absolutely, I've seen it decrease those long-term complications. Obviously, there's always going to be tough cases that no matter what you did, you were going to have some of these issues. But really, we're trying to keep any of these unaffected patients from getting into the mild cases, and the mild folks to stay in the mild category and not progress and not need some of these further interventions. And so all of that strengthening and all of the general physical exercise, whether it's simple walking, whether it's having conversations and talking with people, whether it's singing, whether, any form of physical exercise definitely improves the ability to swallow and vocalize, especially. And so we've seen that, especially when you're doing core work, oftentimes, you engage a lot of both your respiratory muscles and your neck muscles that are involved in swallowing.
Interesting. Yeah, and I know at the beginning of of your discussion, you also mentioned about hypophonia, which I didn't know that was the proper name of a soft speech, but hypophonia, stuttering, dyskinetic speech, and slurring, some of the possible voice changes. And also kind of alluded in terms of part of that could be a culmination of anxiety, medication side effects, or possible infection. And so, that there's just a long list of possibilities of why some of these voice changes occur. What suggestions do you have for individuals and their caregivers to effectively handle and monitor these changes? Because it seems to be a very long list.
Well, I mean, obviously, to monitor them, this is something that, you want to write down before you come in to see your movement disorder specialist and neurologist of kind of, okay, what issues are going on? Because if it's not going on, that's great. Like we won't necessarily deal with it. And kind of where is it on your priority list? Obviously, sometimes if there's a little soft speech, but boy, you can't get out of a chair, I'm going to be focusing on the problems with mobility and getting out of the chair first. But, we may want to address it. Oftentimes, speech tends to be a really good referral when you're in relatively good health. The meds have been kind of evened out. We've got most of the big muscle groups. So it tends to be one of those kind of fine-tuning visits that's really worthwhile. Also, at least in the United States, especially under Medicare, we certainly have certain limited amount of visits that we have with therapists under any insurance. And so speech therapy and physical therapy draw on the same pool of visits. And so everyone should be aware of that. We only have so many visits that we can do every year. But hey, in my Parkinson's patients, I like to use all of them. So if we've had a little bit of a quieter year or time, that tends to be a really good time to go in and address some of these other more subtle issues with the speech therapist when we don't have as big a need for the physical therapy, large muscle visits with the physical therapist for gait and balance or weakness or some other recent injury or fall.
Exactly. And I know throughout the presentation, you also talked about the various treatments, medications that do exist to helping control this drooling, the soft speech and so forth. And so, we received many inquiries through our registration as well as in our questions Q&A. One of our guests is wondering if Botox that is being used as a treatment for drooling can increase dry mouth.
So yes, absolutely. That's the whole purpose of shutting down those salivary glands. So dry mouth can be an issue, in which case then we could, on the next round, cut back on the dose, right? Even though 100 is the FDA approved dose, I certainly had patients respond to as little as 40 units. Or anywhere in between that range. I've even had some people I have to go higher than 100 units off label in order to get adequate control of the problem. However, if dry mouth does happen, I'm glad you brought it up because I don't think, see, it's going to be backwards. Sorry, it's going to be backwards on the camera, you guys, but it's called Zymelt or Xylomelt.
It actually shows fine on my end. Yes.
Okay. So this is something that's cheap, over the counter. And if I do happen to overshoot and we conquered the drooling, but the mouth is a little dry, Zymelt is something that you can use that increases immediately the saliva production. So very, very useful tool, cheap, over the counter at most pharmacies. And that's been really a godsend in order, while we're trying to tweak the dose and find kind of the perfect balance for patients. Sometimes I'll even start I'll start, 40 to 80 units and I'll march upwards, knowing it's like, because I want to get as close to great relief for patients. And sometimes it'll take me a couple rounds of the Xeomin injections of botulinum toxin to get it at that proper balance. It's where you're happy with it, but you don't feel like it's too dry. But at least you've got the Zymelts to sort of give you some temporary relief, because the one thing that's true of the botulinum toxins is they're always temporary, right? They're only going to last 3-4 months, and then they're always going to wear off, and we're going to have to re-inject it. So even if you do notice a little bit of dry mouth, don't worry. It's always temporary. We can just make an adjustment. Okay.
Absolutely. And I love that you mentioned about the lollipop, and obviously taking in the candy. And so this is something exactly. And so, at the beginning of your briefing, you shared about having fun while also working on strengthening your voice. Can you speak more about the importance of having fun?
So, boy, I think if there's one factor in the human existence that tends to predict a longer life, it's really a positive attitude. And I think, if we don't incorporate a little bit of fun in our life, like, why are we here? And so I think that's true in Parkinson's. And the other thing that I think COVID has proven to us is we are social creatures. And with COVID, we got so isolated. And if there was one population that got hit by it, it was folks with Parkinson's and other neurologic disorders, which really saw a decline because they lacked that interaction, that stimulus, that ability to share stories and, harken back to older times and all of those, and experience new things, experience, physical activities like doing like boxing therapy, or ballroom dancing, or things that can really make a difference in our Parkinson's patients, that are exercises that people wouldn't necessarily think are helpful. But, all of those involve social, fun, engagement. I always tell people, especially we're getting a little off topic, but into like cognitive issues, it has to be something that you enjoy. Like, the reason why I always have to customize my treatments is there's no one thing that works well for everybody. Like, if you like crossword puzzles for cognitive therapy, great. But if you hate crossword puzzles, forcing yourself to do crossword puzzles has been shown to make no difference in your cognitive ability. And that's true of exercise, and that's true of these other activities. The only thing that probably goes against that one is social engagement. Like, forcing yourself to go into social, even all of the introverts out there, being an introvert myself, that's something I can definitely empathize with everybody, that it's like, it does help to force ourselves outside of our bubble and outside of our normal routine. Remember, variety is the spice of life, and that stimulation externally really helps motivate us, and ultimately comes back to the point that you started this on, which is fun, looking for fun. That can be fun things you do. You can do it with other friends, loved ones, any any special event, birth, wedding, family get together. These are all things that are part of the long-term therapy, to not isolate ourselves from that. I think that's really important in treating this long-term as a whole person perspective, because the disease affects, the whole of a Parkinson's patient and their loved ones, right? This is a disease that doesn't just affect the patient.
Absolutely. And we can go on a whole different topic when we talk about our emotional, and as well as that social aspects of Parkinson. But as we talk and focus back on swallowing and voice and drooling, you can have fun with those therapies, as you alluded earlier, with practices of loud music therapy, speech therapy, and getting very creative, and even doing things on your own, as you said, because if you're more introverted, reading out loud, picking up your favorite book and just rereading it out loud. I love that you mentioned that, because it just brings a variety of options and treatments and therapies that people can take on, depending on their comfort. So I really enjoyed that you were able to address that. We have our guest, Barb, who wants to hear more about amantadine. You mentioned amantadine possibly having an impact on speech. Could you help clarify if that drug might be good or bad for speech?
So amantadine is one of the oldest medicines that was approved in treating Parkinson's. It's actually FDA approved since about approximately 1963, 1964. So, virtually as old as carbidopa, levodopa, Sinemet. It's a medicine that was invented, originally it was a anti-influenza antiviral that we noticed had some positive impact on certain neurologic diseases. Historically, we've used it for tremor in Parkinson's, dyskinesia in Parkinson's, and occasionally it's made a little bit of a difference in fatigue in Parkinson's and other off-label uses. Since it's come out in its long-acting form with GoCovery, that particular medicine really makes a huge difference in gait and balance issues. And so in using it for speech, so everything I've just talked to you about is what I usually use it for. The only subgroup of speech I use it for is if I think your speech is a dyskinetic pattern, specifically that the speech is occurring, especially either when you speak or when you valley, or when you're having other manifestations of dyskinesia, the Michael J. Fox extra movements, and that I think the speech is being affected by that. So only if your neurologist suspects that, then amantadine is a good choice. I wouldn't give it broad strokes to everybody. It doesn't work for every speech problem. It doesn't work, from my experience, in hypophonia, which is the soft speech. And so only in this subcategory. But that's why you come to your movement disorder specialist and your speech therapist, right? We have an ear for these things, and we're watching everything that's going on with you to try to determine if you're a reasonable candidate to try it or not, right? Just like I said, similarly, when I brought up the stimulants, I only consider the stimulants in people who have a really long delay time in their speech. If their thought to speech lag time is very, very long, and they're really slowing down, it's only that category that I would really consider using that I've seen significant benefits. And it has to be obvious. That shows up when you use a stimulant or amantadine. You really should see that difference. You're not going to have to wait 3 months. You should really see it within 4 weeks or so.
Wonderful. Well, after this, so as we close out our Q&A session, Dr. Martinez, and I want to thank you for your time again. Are there any final comments or any key takeaways that our community can take away after learning so much about, speech changes, voice, drooling, swallowing? Is there anything that you can share with our community?
So the one thing, because oftentimes there's a lot of things going on with Parkinson's, at your visit with your physician, when you feel like the speech is a big enough problem, prioritize it as such to your physician. We are happy to make those referrals. Like, we will do that in a heartbeat. But sometimes there's so many other things going on that sometimes gets short shrift. And so, I guess I'm encouraging everybody to bring it up as a priority when it's the right time. Realize that sometimes your physician will prioritize other things that might be more life-threatening or might be more disabling, and yet we never want to ignore it entirely. But that, hey, I know we're a group. When we're in that room together, myself, my RN, and my and you and your loved ones, like, we're doing kind of a group approach to this, right? We're trying to hit all the things as best we can. And, don't be afraid to bring it up. I certainly would never mind that, because sometimes my brain is thinking about all the other complexities and how to educate you about that. But, writing a referral for speech therapy is easy. But sometimes if you just bring it up, you're like, this is a good time for us. We have the time. We have the ability to drive there. We have the willingness and interest to be able to get involved in that. Then absolutely bring it up to me. Don't wait for me to say it. Like, in terms of these types of problems, you being proactive with it is great. Also realize a number of the things that I've talked about, not every physician will have that available. Not every physician knows how to inject botulinum toxin. Not every physician is as comfortable with some of these particular medicines, but you can always bring up the ideas, and sometimes they will sub-refer you to folks for that specific treatment who's in relatively close proximity, because it's not something that you need every day. It's only something that you might need quarterly or so. So I'm just telling everyone to be proactive with these types of issues. And at least you have some things to at least engage with and discuss, and your medical team can see if they're right for you.
Well, thank you so much, Dr. Martinez, for your time, expertise, and wisdom that you've shared with our community of Parkinson. I hope many of you who joined us today learned something new, as well as, we're encouraged to look at new opportunities and treatments and therapies that could help with your speech, swallowing, and drooling. So again, I want to thank you, Dr. Martinez, for your time. We have a couple parting final messages that we want to share with you before we conclude today's program. As I mentioned, on behalf of the Parkinson's Foundation, we thank all of you who joined us today. A follow-up email will be sent with a survey. Please tell us what you thought about today's program. You also receive a link to today's presentation and additional resources related to today's topic. Again, I do apologize if we didn't get a chance to address your question. However, if you have any question, please do not hesitate to contact our helpline by calling 1-800-4PD-INFO or email at helpline@parkinson.org. You can also use that same contact info to order our free resources, publication books series, and our hospital safety kit, which includes, a listing of medical contacts, medication list, that is very helpful during your stay at a hospital. We want to thank you for joining us today and hope to see you in Zoom land again. Bye for now.